Greetings of the day, folks. In this video, we shall discuss about aplastic anemia. Aplastic anemia is a disorder of hematopoietic stem cells that usually presents with pancytopenia, and most cases are acquired and idiopathic. But aplastic anemia can also arise from an inherited bone marrow failure syndrome, such as Fanconi anemia, dyskeratosis congenita, and Schwann-Diamond syndrome. Approximately 20% of the patients may be associated with a drug or chemical exposure. Approximately 10% of the patients are associated with viral illness, such as viral hepatitis, EBV, CMV. Clonal hematopoiesis is a feature of aplastic anemia, with MDS and AML developing in 15% of the patients. So the diagnostic criteria for aplastic anemia is a diagnosis of exclusion, and other causes of pancytopenia should be ruled out. Prognosis in aplastic anemia is dependent on the disease severity and patient's age. There are 3-4 categories of aplastic anemia. Moderate or non-severe aplastic anemia, in which bone marrow cellularity is less than 30% and absent of criteria for severe aplastic anemia, and at least 2 of 3 bloodlines are lower than normal. In case of severe aplastic anemia, the bone marrow cellularity is less than 25% with normal cytogenetics, or bone marrow cellularity of less than 50% with normal cytogenetics and less than 30% of residual hematopoietic cells, and 2 of 3 peripheral blood criteria, such as absolute neutrophil count of less than 500 per microliter, or platelet count less than 20,000 per microliter, and absolute neutrophil reticulocyte count less than 20,000 per microliter, and no other hematologic disease. There is also another category which is known as, and there are no other, and known as very severe aplastic anemia, in which the criteria of the severe aplastic anemia are met, and the only thing that varies is when absolute neutrophil count is less than 200 per microliter. So the bone marrow in the severity will be either less than 25% or less than 50% with normal cytogenetics, and 2 of the 3 will be, and here it will be changed as 250. That's the difference in severe and very severe category. So the various commonly used drugs that can induce red blood cell disorders include the sideroblastic anemia can be seen in the patients who use chloramphenicol, cycloserine, ethanol, isoniazid, and pyrozinamide. The topic of discussion, that is aplastic anemia, can be seen in patients using acetazolamide, anti-neoplastic drugs, carbamazepine, chloramphenicol, global salts, hydantoins, penicillamine, sulfonamides, phenylbutazones, quinacrine, and etc. The other drugs in G6PD deficiency are dapsone, doxo, rubicin, methylene blue, and etc. And immune hemolytic anemia can be caused by cephalosporins, penicillins, NSAIDs, quinidine, and rifampin. So the diagnostic testing in case of aplastic anemia is, as we all know, bone marrow biopsy is required for the diagnosis. Bone marrow results in patient with aplastic anemia may be difficult to distinguish from hypocellular MDS and paroxysmal nocturnal hemoglobinuria. Evidence of dysplasia or abnormal cytogenetics is indicative of myelodysplastic syndrome, and PNH clones can be detected by flow cytometry of the blood or bone marrow. So the bone marrow results in so you have to be careful whether the bone marrow is showing whether PNH or hypocellular MDS. It may be difficult in the case of diagnosing the patient with aplastic anemia. So we have to differentiate it with abnormal cytogenetics and also flow cytometry in case of PNH. Coming to the treatment part, so the suspected offending drugs should be discontinued and exacerbating factors should be corrected. Rarely, spontaneous recovery of normal hematopoiesis can occur, usually within 1 to 2 months of discontinuing the offending drug. Once the diagnosis is established, care should be provided in a center experienced with aplastic anemia. Therapy is optional in moderate aplastic anemia unless there is a transfusion dependence. However severe or very severe, requires urgent treatment given the high risk of infections and hemorrhagic complications. Patients younger than the age of 50 with severe aplastic anemia should be evaluated for the eligibility of allogenic stem cell transplantation. And patients over the age of 50 with severe aplastic anemia or younger patients without stem cell transplant donor are treated with L-thrombopag 75 to 150 mg per day along with cyclosporin and anti-thymocyte globulin. So the overall response rates at 6 months were 94% and 2-year survival would be around 97%. Aplastic anemia typically does not respond to ESAs. Granulocyte colony stimulating factor may be effective in some patients and can be used while awaiting definitive therapy. However, there is no role of any survival benefit with the use of these agents at all. So the immunosuppressive therapy with cyclosporin and ATG should be considered only in the patients with severe aplastic anemia who does not undergo stem cell transplant. And overall response rate at 3 months were between around 60 to 80%, and most responses occur by 6 months. And corticosteroids alone have not been shown to be effective and can increase the risk of infections and should not be used in treatment of aplastic anemia. So the corticosteroid does not have any therapy. Stem cell transplant treatment can be used in patients in a center which has got experience in managing aplastic anemia. And so when feasible, stem cell transplant from an HLA identical sibling is generally recommended and has achieved a long-term survival rates of 60 to 70%. And transfusions, RBC transfusion should be kept at a minimum to avoid low immunization. Prophylactic platelet transfusions are generally recommended if the platelet is less than 10,000 per microliter. And transfusion is obviously irradiated leukodepleted products and is preferred to decrease the risk of alloimmunization. So the dose of L-thrombopag is 50 to 150 mg per day, and in some books it will be 75 to 150. And a thrombopoietin agonist, which is shown to be effective in some patients who do not respond to cyclosporin and ATG. And it may be an option for patients with refractory severe aplastic anemia. Thank you very much.